everyone. Welcome. Excited to see you all here. We'll just give it maybe a minute or so to let everyone trickle in, and then we'll get going with this webinar today, which I'm very excited about. And if while we're just waiting, we'd love to know if you want to just type into the chat where you're tuning in from. It's always wonderful to see where everyone is listening from. I'm in Dallas, Texas, and Liz is
I'm over in Silverton, Oregon.
Oregon, Charlotte, North Carolina, Brazil, or Lynn's Pharmacy, Brazil, Indiana. For a moment, I read it as Brazil. I'm like, Brazil. Nashville, Los Angeles. Yeah, we've got people from Mountain View, California, Florida, Ohio. Hello. Appleton, Wisconsin, Florida, Montana. Wonderful. Thank you. Columbus, Ohio. Great. Awesome. Well, it's lovely to have you all here. If you're tuning in live, thank you so much for taking some time out of your day to hang out with us here at MBL. And if you're listening to the recording, thanks you so much for listening to the recording and circling back. I know that being middle of the day, it's hard for everyone to join. But I'm really excited about this topic. We were just chatting earlier that this is actually a new topic for us to talk about at MBL, but I think it's a really important topic because in the spirit of women's health, fertility and the fertility discussion is a bit of a question mark for people, but it can be a deeply personal journey for many women. And if any of you are currently working with women who are struggling with fertility or pregnancy, or if you yourself have gone through your own personal journey of fertility, we hope that today you glean some clinical pearls. Dr. Bartman shared her slides with me, and we reviewed her slides prior to today, and I can tell you that it is packed full of amazing clinical pearls that she just spouts off the tip of her tongue. So definitely tune in, get comfortable, grab your coffee or your tea, and settle in for today's session. We are recording this, so you will receive the recording and the slides. And by the end of the week, I think Nikki might even be putting the slides in the chat for you to follow along with. So you will be receiving these by Friday. And with that, I will introduce our speaker. Liz is going to go through some of her topic, and then I'll wrap it up at the end with some more practical applications and basically how do you put all of this information into a practical protocol for your patients. But just a little bit about Dr. Liz. Dr. Liz Bartman is currently serving as Chief Medical Officer at EndoAxis, where she specializes in advanced hormone analysis and targeted root cause driven treatment strategies. Formerly a clinical educator at Precision Analytical, she has interpreted thousands of complex hormone and organic acid panels and has educated practitioners globally on hormone health, metabolomics, and functional genetic nutrition. Dr. Bartman is passionate about bridging conventional and functional medicine to deliver personalized evidence-based treatment strategies to patients and providers. And so with that, I will turn it over to Dr. Bartman. Thank you.
Thank you so much. I'm so excited and honored to be here with all of you today and excited to dive into a topic that I think really is so relevant. It's always relevant, but it's so relevant in this day and age. Let me share my slides here as sometimes I'm not always tech savvy. Here we go. All right. So today I really want to dive in to both fertility support as well as testing options that can really give you insights into what's going on in your patient's fertile journey. Let's see, I'm still not getting all my slides. Can you, anyone just give me a thumbs up or let me know if the slides are being
Yes, we can see
bigger?
the slides. Yes.
Awesome. And are they moving?
No. Oh, there we go. Now they're moving. Or you
Okay, wonderful.
Yep.
Okay. So today, let's just dive in and we're going to start with just the basics, right? And really in my clinical practice, where I like to start is preconception care. And there are a few things that I always like to keep in mind when I'm working with my couples who are looking to get pregnant. Number one, it takes two to tango. So I never isolate just the female part of the equation. We want both partners involved when it comes to really optimizing nutrition, optimizing lifestyle, optimizing environment. nutrients, supplements, right? They both must be engaged because we don't want to just, support getting pregnant, but we really want to support the health outcomes during pregnancy as well as that healthy baby. And we know that sperm quality matters when it comes to conception, but also when it comes to healthy pregnancy outcomes. In fact, there's more and more research coming out regarding the impact that sperm has and the quality of sperm when it comes to preeclampsia risk for women and even preterm labor. So we really want both not just to get pregnant, but for the health of the pregnancy and for that healthy, happy baby, we want to optimize both egg quality, womb quality, and that sperm quality. Now, just some statistics to throw out there. A third of all infertility cases is male factor only, right? A third is female factor only, and the remaining third is either unknown or kind of a mix of both. Now, I always like to also emphasize that when we're talking preconception care and fertility as well as infertility, it is not just a personal health, it is a global health problem. So reproductive health is environmental health. There are so many toxins that we are getting exposed to, even just exponentially in the last 30 odd years, right? Micro and nanoplastics are the biggest ones. And I'm going to harp on them a little bit because they truly are something novel in our environment that has bioaccumulated in mass, right? We have more nano and microplastic exposures than ever before. And they really were never in our environment prior to the 1950s. So we're starting to see this health effect, and we know that they act and behave kind of like hormones, right? They're xenoestrogenic and they like to store in hormone sensitive tissues, including the testicles, the ovaries, the placenta, the brain, and the adipose tissue. So when we're trying to optimize health, we want to do as much as we can to reduce oxidative stress, improve nutritional health and status, but also be aware of some of the environmental factors and what we can do. Sometimes it's like they're out there. There's not a lot we can do, but if we can control our immediate environment, we want to make as big an impact to that environment as possible. And as we're seeing micro and nanoplastics elevate in our environment, we're also seeing infertility go up. So we do see right now globally, 1 in 6 couples struggles with infertility, and that's pretty massive. Now let's just go through some stats. I think sometimes it can be misleading. I think women, especially, they feel like in their 20s, they should be really fertile, and they are. That is their most fertile time, right? And yet, a healthy 25-year-old female who's trying to conceive for the last 3 months has an only 18% chance of conceiving their next menstrual cycle. You would think, when I read that statistic many years ago, I was like, man, you would think that's a much higher, right? And yet it's not really. There's a lot that goes into getting that successful implantation. So even at our peak fertile time, 18% chance of getting pregnant after we've been trying for about 3 months in our 20s for women, right? In our 20s. In our 40s, as women age, that chance reduces by more than half, right? It's about 7% chance. And a big part of that is because egg quality is declining, oxidative stress is increasing. And sperm quality, depending on age of partner, is also starting to get more stressed and decline. Now, as infertility risk goes up, as we get older, miscarriage risk also increases. So now we're struggling with conceiving, but we're also struggling with maintaining pregnancy. So we really, again, this is where preconception care is so important. Now, keep in mind, women, female-bodied individuals, are born with 1 to 2 million eggs. Okay, that's a lot. And we have those 1 to 2 million eggs in our ovaries in our second trimester of development in our mother's womb, which, if you go deeper, means you as an individual, as an egg, were present in your mother's ovary when she was still developing in her mother's womb. That means that preconception care is not just impacting your baby's health, it is impacting your grandbaby's health, right? Like, it is profound. And it's why, again, I just harp on it so much because it is so critical when we're trying to better and improve not only our fertility outcomes, but the health of our children, right? And our grandchildren. Now, by the time we go into menarche, those eggs that we have, there are a lot of just chromosomal errors. There's a lot of oxidative stressors, and the ovaries really do a good job of saying, is this stable and compatible with life or not? Every month, it is just killing off those eggs, right? So those cells are going through apoptosis because they're going through a checks and balances system and saying, is this a viable egg? Is this chromosomally stable? Once you hit menarche, so your very first menstrual period, you only have about 3 to 500,000 eggs. And then by the age of 37, you're down to 25,000 eggs, right? So every month you're losing around, in a normal healthy cycle, 1,000 eggs just to that chromosomal checks and balances system. Now, increase oxidative stress, immune stress, nutritional deficiencies, all of a sudden, you're losing more eggs than even that. This is why, again, we really want to work on optimizing that just overall health. So again, micro and nanoplastics really are involved in that reproductive dysfunction, and they're increasing DNA damage, they're increasing that rate of apoptosis, and they're causing a decline more rapidly in our egg count and our sperm quality for that matter. But they're not the only toxins. Of course, we also have air pollution, we have cigarette smokes, we have the chemicals, phthalates, parabens, bisphenols in our beauty products, in our personal care products, pesticides, the liners and chemicals used in fast food or even just takeout foods, right? And the containers that they're contained within, water pollution. It's all around us. And it's all creating that reactive oxygen species activity, damaging eggs, damaging sperm, and reducing fertility outcomes. So again, we really want to address that root, right? We want to optimize health, starting with environment, starting with nutrition. Now, let's say we're working with couples. We have both partners 100% on board because we want both partners 100% on board. And they've been trying to conceive for about 6 months. Depending on their age, if they're under the age of 35, technically speaking, they have to be trying to conceive for a full year before the diagnosis of infertility is made. And that diagnosis is made if there's an absence of a full-term pregnancy. If they're over the age of 35, 6 months is that window. I would say, given the fact that we know younger couples should be more fertile, if they're struggling even at 6 months, I would still do more advanced testing. But basically, that's what we're saying. Once they have a diagnosis of infertility, are we doing anything different? Well, we're testing a little more aggressively. We're going a little deeper, looking under the hood a little bit more than just the routine standard hormonal analysis. That said, with preconception care, you can optimize and start evaluating nutritional markers, gut markers, hormone markers at a very early stage to ensure optimal success so that hopefully the diagnosis of infertility never has to be made. Now, again, both partners do need to be worked up if they've been struggling to conceive for that 6-month window. There is more analysis that does come on the male side that is pretty affordable, pretty easy to do, but tends to get overlooked. And so even just a sperm analysis can be done earlier than later and should be considered if you have, even at that 6-month mark, kind of some questions about whether or not there's like concerns of why I'm not getting pregnant, right? Why is this couple not getting pregnant? Now, this is a pretty comprehensive list of a lot of causes that can lead to infertility, right? And I do have purple wording as female specific conditions, blue is male specific, and black is both genders, right? And this list, if you have, I would argue that if you have a patient that has any one of these conditions, or a couple, right, that has any one, either partner has any of these conditions, start that more in-depth analysis for infertility workup sooner than later, because the chances, right, of an unsuccessful pregnancy for 6 months or more is higher if they have one of these conditions or multiple of these conditions. But again, as I said, sometimes education is the most important part. I always like to share this screen with my patients who are looking to conceive, right, or who are struggling with conception. The reason being, I cannot tell you the number of patients who have come to me and said, well, I track my cycles. I know when I ovulate, and we try to conceive. As soon as I ovulate, we're trying to conceive, right? We're working on our conception workup. We're having sex. We're, doing all the things. And it's like, well, by the time you ovulate, you're 5 days too late, right? Because that egg only lasts for 12 to 24 hours. Sperm can last up to 5 days in the womb. So that sperm, we want that at the ready in the fallopian tube when that egg ruptures. We want the sperm and egg to meet right away to maximize conception. If they have ovulated and then are trying to conceive, after that are starting to engage in sexual intercourse after ovulation, they've missed their window. So I always encourage them to just start tracking their menstrual cycles first and foremost and educating on when that fertile window starts. How can you track if you're ovulating, especially if you have irregular cycles? Well, cervical mucus is really the most efficacious way to know if you've ovulated, that change in the cervical mucus quality. I'm not going to read this verbatim. There's a lot of words on these slides. You're going to get access to all of them at the end of this presentation. But I just wanted to put some of the ways to track whether or not or when you ovulate here in more detail. So basal body temp is another way to track. Basal body temp, it's tricky because if you have hypo or hyperthyroid, you could have off basal body temp that's not fluctuating as it should, and that can throw off that reading, but you will still have a cervical mucus change, right? Luteinizing hormone, this LH strips, very cheap, very easy to test. It's looking for that surge that happens that's triggering ovulation. Now, these can be off if you have PCOS. So LH tends to be just globally higher with PCOS. So that can throw off accuracy of that as a testing parameter. But again, cervical mucus will change if you ovulate. And then devices, there's a lot of femtech on the market these days. They're very sensitive. They'll show you changes. They are not specific. They will not tell you why you have changes. If you have abnormalities, they won't give you those insights. But they will show you like, oh, this is roughly when you ovulated and how robust that hormonal change was. So those can definitely be utilized as well. And again, you want patients to track for 3 to 4 months while they're doing changes to their nutrition, to their lifestyle, to their stress, right? We know stress is a big one when it comes to fertility success because of the role that cortisol plays on blood sugars, on inflammation. We'll get into that in a minute. But once they've tracked and they're doing all these great healthy changes and they know, okay, this is when I'm ovulating, then they just count backwards 5 days, and that is that fertile window. Now, male-bodied partners, those donating their sperm has about a 64-day lifespan from the day of capacitation to the day of ejaculation. So really it's about 2 months that you want to be enhancing nutritional status for men to enhance that sperm quality and morphology and density, like how much sperm are they making and generating? What is their motility, right? You can really do a lot with nutrition, but it really should start about 2 months before you plan to conceive. But even a few weeks before that fertile window, you really want to double down on what you're doing to maximize success of that sperm health. Avoid restricted clothing, avoid heat, avoid substances that are going to kill or oxidize that sperm. Really important. And remember, the egg that you get pregnant with today, it started its checks and balances system 3 to 4 months ago. So that's why when we're looking at preconception care, we really want a minimum of 3 months, but ideally 6 months. And I would even argue a whole year if you can. Age is going to be a predicting factor there. Women in their 35, 40, kind of year span, you probably, if they can give you 6 months, that's going to be great. A younger woman, a full year of commitment, for both couples is really ideal if they can. Now, when we start thinking about what could go wrong, why is my couple not conceiving, right? Why are they struggling? We really want to understand physiology, and then we can work backwards. So a normal, healthy, optimal conception begins with egg rupturing and sperm being at the ready and meeting, right? So again, that sperm's going to last in the womb. It's going to be traveling through the fallopian tubes. It lasts for about 5 days. As soon as that egg is ruptured from the follicle, we want that sperm to be at the ready. It's going to form a zygote over about a 2 to 3 day window. Around day 4 to 5, it's forming into this blastocyst. This blastocyst, right, is now a foreign body. It is now half mom's DNA and half dad's DNA. So immune function is really important to assess because if you have a hyperimmune stimulated individual, that female, that body might be attacking that blastocyst, right? So we really want to support immune function. That blastocyst will form a trophoblastic layer. That trophoblastic layer of cells is what really allows that cluster, right? That blastocyst, of that accumulation, that new developing embryo to adhere to the endometrial tissue and then to burrow. Now that trophoblastic layer is predicted, its health is predicted by sperm quality. So you can have an optimal egg, but if that sperm did in fact, start germination, but wasn't quite up to par, wasn't quite optimal or healthy enough, that trophoblastic layer may not be ideal, and that can reduce adherence to that endometrial tissue, and that can result in a failed implantation. We see this both in natural conception. We also see this with IVF. And that's why it's really important, again, to be treating both partners, because with IVF, the fail rate is partially the sperm quality. And we really want to have that optimal sperm to form that trophoblastic layer, because in the test tube, basically, you're extracting all of those eggs. You can really assess and pull out and get the most viable, optimal egg. You're washing it with sperm. You're getting that blastocyst to form, and you're doing around a day 4 or a day 5 implantation. But whether or not it adheres, that's up to the body and the immune system and all the mechanisms that are at play. You're not injecting it right into the womb, right? Like, you're inserting that blastocyst, but it still has to adhere. It still has to do the work. And that sperm is part of that equation, a big part of that equation. I digress. What else is happening? Well, can it burrow? Is the endometrium nice and healthy? Is it too thin? Is it too thick? Right? Is there a hostility to that endometrial response? Is there an immune hostility? Is there an inflammatory hostility? Are there clotting errors? And I want to throw this one out as well, right? Here are the questions. Because if you have a factor 5 or a factor 2 Leiden carrier, so they may not have frank factor 5 Leiden, but they're just a carrier. They have one gene from mom or dad, right? That is that gene trait, and then one normal trait, right? Even a carrier is at around 40% more inflamed, or more, this is my brain as I'm like getting into my passion, going on my tangents. They are in a more hypercoagulable state, just 40% above baseline, right? So you may not be in full on, hypercoagulability and clotting risk, but you are at about a 40% greater risk for clotting above like a baseline, which means and I say all this because that blastocyst, not only does it have to adhere to the endometrial tissue, but it has to burrow. When it's burrowing, it's creating cell injury. Now, that burrowing process should recruit lots of healthy immune cells. Histamines come in and create vasodilation. They start creating this nice nutrient. They like are bringing nutrients to that cell to really start to propagate germination. But if you are a carrier of factor 2 or factor 5, and you are under increased stress, you have poor nutrient bioavailability, you are in a naturally just overinflamed state, putting inflammation on top of your hypercoagulability can make you more at risk for forming a clot around that blastocyst. If you form a clot, it cannot access blood, it cannot access nutrients, and you end up with a miscarriage. So, that's one that I don't think gets thought about a lot, but I do see it. And I think it's because I do a lot of nutrigenomic and genetic testing, but I do see that as a risk that should not go unaddressed, right? Keep it in the back burner if you're trying to figure out, why is this couple not conceiving? And there are genomic like polymorphisms and tests that specifically look at factor 5 and factor 2 Leiden. So again, we start asking ourselves, did they ovulate? Was there an egg present, right? Was the sperm there? Could it travel? Did it get there in time, right? Is that trophoblastic layer healthy? Do they have appropriate immune response, endometrial response, and are they clotting appropriately? We may also want to think about thyroid, inflammation, gut health, right? When we think about inflammation, 60% of our immune cells are, some say up to 70, even 80%, depending on the study, are regulated by your gut. So is there an underlying dysbiosis? Is there an underlying malabsorption? Are they not absorbing nutrients appropriately? These are all things that really need to be assessed if there's that trouble with conception. I always like to review STI history as well. These are sexually transmitted infections. They may be in a committed relationship now, but especially females, if they've had a history of chlamydia, even if it was diagnosed, treated, it's resolved, chlamydia is one of those tricky STIs that can cause scarring to occur on the fallopian tubes. So even if they have a history of chlamydia, it's important that you know that going in, that you screen and make sure it is fully resolved if necessary, but also that you consider more advanced testing to see if they have patency of those fallopian tubes, because chlamydia can go undetected for months to years, as it doesn't always create symptoms. So depending on when they were diagnosed, how they were treated, how it resolved, there may be concern for fallopian tube scarring there. So that's one I always like to throw out. Again, for male-bodied individuals, varicoceles are one of the most common causes for poor sperm capacitation. And so it's about 30% of men will struggle with a varicocele at some point in their lives. It's an important one to assess for. As well as medications, any drug use. Are there environmental stressors, right? So all of a sudden you have like this list, right? And you in this corner, I have all of like all the labs that could show you are these concerns. But I want to throw out the idea that what if you could just look at a few blood markers and a few urinary markers and assess whether any of these other concerns are present or not, and determine where do you want to spend your money for the next advanced test if needed? Or is there enough information just from the blood and urinary markers to inform you about where you want to start treating and assessing even preemptively? So to understand what you can gain from urinary metabolites, you need to understand what are hormones doing in the body and how are they processed? How are they made? How are they processed out of the body? And how are metabolomics influenced by other physiologic activity within the body? So number one, we have to remember sex hormones and cortisol are steroid hormones. So they're a fat, right? They're cholesterol based. Any cholesterol based substance has to go through a biotransformation into water to eliminate from the body. And there are a series of enzymes that do this for us, and they're located in specific tissues. So not only do you want to know what are the enzymes involved in that transformation, but what tissues are those enzymes expressed within, and how could that impact what we're seeing? So number one, I'm going to start with estrogen because that's the most well documented, it's the most well researched, and it's talked about a lot. So a lot when we start talking about this, people are like, oh yeah, light bulbs often turn on. Oh yeah, phase one, phase two detox, right? So phase one detox is a series of hydroxylation enzymes through a family called the CYP450 family of enzyme. It's a whole host of different enzymes involved in how we process out lots of different chemicals. But for estrogen in particular, we're looking at CYP1A1, CYP1B1, and CYP3A4. CYP1A2 is in there as well. It's more minor for estrogen, but it does play a role. It's very important for caffeine metabolism, though. And there they are again, just on the slide as well for reference. So phase one is basically, again, it's hydroxylating that cholesterol-based substance, that hormone. And then we have phase two. Phase two is taking those intermediates and it's conjugating it so that it can be bound into bile and either excreted into stool or into urine. We have a set of different phase two enzymes. COMT is the most discussed. It's going to methylate and deactivate the catechol intermediates of estrogen. That's 2-hydroxy and 4-hydroxy. So it's adding a methyl group to those catechols to then biliary conjugate and excrete out. We also have sulfation. We have salt 1A1 and 2A1 involved in 16-hydroxy elimination. 16-hydroxy is a very bulky intermediate. It actually has a role as being estrogenic because not just estrone and estradiol can bind to those estrogen receptors, but 16-hydroxy can also bind to those estrogen receptors and create more of a proliferative response. So it's one that we like to track. It does have benefit, but it also has risk. And again, it's not methylated, it's sulfated. We like to look at that guy. We also have our glutathione reduction. These are our GSTs, and of course our glucuronidation enzymes. And this is through bile. This is direct bile conjugate. And then in phase three, I like to think of this as kind of sweeping up estrogen into little piles. That's phase one. Phase two is taking those piles and putting them into garbage bags. And phase three is taking that garbage bag to the dump, quite literally. Phase three is gut elimination. And there, I call it the rats, but beta-glucuronidase is made by a set of bacteria in the gut called the estrobolome. And beta-glucuronidase, as its name implies, is an ACE. It's a cleaving enzyme. So it can go and actually cleave off those side chains that have deactivated the estrogen, making that estrogen active once more, recirculating it. So if we're looking at the womb and we're thinking estrogen is like the bricks, right, lining the womb, lining the uterus. Progesterone is the mortar that holds it all together. Well, if we're getting a lot more estrogen in circulation or it's not eliminating appropriately, or we're making a lot of 16-OH that can go in and hit on those receptors and proliferate even more, we may have a lot of bricks. That can make it harder for implantation if we're estrogen dominant, right? So we really want to start looking at these pathways and considering, are there metabolites in urine suggesting that maybe there's an error in how we're clearing or processing that estrogen and how it's working at a receptor level? The other thing to remember with urine is that it really is bioavailable. It is receptor active hormone. So again, we see that little rat there eating that glucuronide side chain, reactivating that estrogen. So anything we can do to help conjugate and eliminate that estrogen can help improve fertility outcomes if estrogen excess is a concern. But it can also shine light on what may be impacting metabolomically or at a cellular level that oxidative stress and quality of egg or sperm. So here you can see, like if we are seeing high 4-hydroxy in urine, well, what could upregulate expression of CYP1B1? What could be increasing that 4-hydroxy elimination? Well, polyaromatic hydrocarbons are a big one. This is anything smoked, charbroiled, barbecued, right? Massively damaging to egg and sperm quality, huge oxidative stress. If we're seeing elevated 4-hydroxy, that can be a big motivator to say, you need to cut out the smoked and charbroiled meat products, right? Anything lit on fire and inhaled into the lungs, or any smoke in the environment. And depending on where you are located, there could be a lot of smoke just from forest fires, right? So really being mindful and looking at those metabolites can tell us, could there be an oxidative stress? Even if estrogens are looking beautiful, even if E2 in blood is looking great, LH and FSH are looking fine, progesterone's good, testosterone's in balance, and yet this couple is struggling to conceive, and then you look at their urine and you're seeing high 4-OH, okay, there's some oxidative stress there. Their hormones are balanced, but they've got some underlying cellular stress that needs to be addressed, right? So really looking at the importance of these metabolites. Inhibitors of COMT, I mean, we can just look at caffeine, right? It depletes those methyl groups. Alcohol depletes those methyl groups and can lower that methylation response. We can see that clearance start to dwindle on urinary reports. Lead is a direct inhibitor of COMT. And of course, we have lots of nutrients required for that enzyme to work optimally. If you're deficient in magnesium, B6, folate, B12, trimethylglycine, which is betaine, you may be lacking the right resources to optimally process out your estrogen. Now, what does that tell us about the viability of the eggs? Well, if you're not methylating well, you may not have appropriate DNA or chromosomal stability. You may have some oxidative stressors increasing damage to DNA, both at the cellular level for that individual, but also at the egg level or at the sperm level. So again, really important that we look at the nutrients as well as those environmental inhibitors. Now, estrogens aren't the only one that go through a biotransformation process. As I mentioned, testosterone, DHEA, and cortisol are all steroidal hormones as well, as is progesterone. So they all require varying degree of transformation. With DHEA, testosterone, and progesterone, it's primarily sulfation and glucuronidation. And again, here you can see, and I'm not going to read this out, there's a lot here, but it's to emphasize the importance of where environment can play a role and what we're seeing metabolomically, and how that can then play a role in the success of that patient's ability to conceive, right? Or hormonal health. Put on progesterone here as well. Progesterone and testosterone also go through 5-alpha and beta reductase response. Blood sugar dysregulation, chronic stress, immune stress can all push more towards the 5-alpha side, although chronic GI stressors, that need for rest and digest, can actually push more towards beta. So looking at those relationships can really inform us, is there more of a blood sugar and acute inflammatory response happening that we need to address to support their fertility outcomes? Or is there more maybe a gut issue or a chronic immune stressor that we need to support in order to optimize their health and their ability to conceive successfully? Cortisol, same thing, right? We can start seeing these patterns unfold. And I'm just going to show you a snapshot of what a Dutch test looks like, because this is where we start seeing those metabolites, right? And in this case, I wanted to point this one out. Here we have someone who, if you only looked at their estrogen, you'd be like, oh, they're actually looking on the low end of range. We need to support estrogens. And yet, look at how robust their 16-hydroxy activity is. 16-hydroxy and E3 are both metabolites of estrogen through the CYP3A4 pathway. And again, this is a tissue proliferator. These are heavily sulfated. When we see this elevated, we think gut, right? This can really point us towards there's an issue with the strobilum or sulfation or inflammation in the GI. They're also really poor methylators. So although they're not making a lot of estrogen and they really can't methylate it either, which is not a good sign. They should be able to methylate that low level pretty well. So here we can start to see, okay, we really need to support their gut. We need to support immune function. We need to support nutrient function. And yet, progesterone's looking decent. They are a little more on the beta path. And that can tell us, pushing more rest and digest there. But overall, it's really, for that individual, it's looking deeper. It's looking under the hood and saying, oh, I think we need to support that gut. We need to support methyl. We need to support environment, right? And here you also see this is their cortisol. Sky high cortisols. Now, something to keep in mind, glucocorticoids, including exogenous, as we would find in our steroids, as well as our own endogenous cortisol, upregulate CYP3A4 expression. If you're under a lot of stress, you're going to skyrocket, right, your estrogen clearance through the 16-hydroxy pathway, increasing that proliferative response to those cell receptors and potentially increasing that kind of inflammatory potential and reducing success of implantation. So really important that, if we're looking at hormones, we also look at the adrenals because they impact each other. And again, we know stress can really impact success of that conception as well of implantation, not just because of what it's doing hormonally, but also because of what it's doing to the immune system and how it's augmenting those immune cells that can then again also start attacking non-self more aggressively, which would be that blastocyst. So when we're looking at blood, we look at a single point in time. That's why there's some limitations when we look at our sex hormones, because sex hormones are pulsatile. And I always like to point this out, because if you're taking a single blood marker at a single point in time, you're really only capturing that one, whatever was flowing, whatever sex hormone was in circulation at that point. And again, progesterone has a half-life of 15 minutes. It bounces a lot throughout the day. We know that progesterone is only made for 10 to 14 days out of the month. It forms from that transient endocrine tissue called the corpus luteum. That corpus luteum only forms if a follicle ruptured and an egg was released. We could potentially misdiagnose low or high progesterone if we're not capturing a diurnal collection. And in fact, reporters that this specific image came from the study, at the end of their conclusion of the study was you need to collect progesterone at least 4 times in that luteal phase of the cycle to know what their average progesterone level is, because a single point in time, you could miss a peak or a trough. Right? Testosterone tends to have more of a diurnal pattern. It tends to surge in the morning and go down throughout the day. Estrogens have a lot more variability as they relate to cortisol, but also FSH surges. So there can be a lot of variance throughout the day, a little more consistency though with estradiol. But in urine, you really are getting that full diurnal average, right? So you get to see the peaks and troughs averaged out throughout the entire day. So definitely a more comprehensive view, specifically when you're looking for those very pulsatile hormones, of which progesterone is the most bouncy. So proposed testing, putting this all together, I would suggest when you're looking for really optimizing health of our couples trying to conceive, that we look at a day 3 in our female patients, day 3 testing of those peptide hormones, the signals from brain to ovary. That's when everything should be at baseline. If they're too high or too low, we can say with pretty good certainty that there's a problem, right? After that, the peptide hormones also become quite pulsatile. So we really want that day 3 or roughly 2 to 5 of the cycle for that blood test. We want to look at metabolomic or metabolic activity as well. So we want to look at thyroid function. We want to look at blood sugars, right? We know that women who are insulin resistant are kind of in the upper range of A1C, kind of like in that pre-diabetic even status. While they're trying to conceive, if they get pregnant, they're at a greater risk of developing gestational diabetes. We don't want that. We want to really improve blood sugars, right? So always checking on the blood sugar status, checking in on vitamin D levels as a critical hormone for fertility. And then looking at day 21 testing in urine so that you can see that metabolomic picture unfold. You can see where is environment or nutritional deficiencies possibly impacting their ability to conceive, even if their hormones look great. And it can show you, of course, if hormones are not looking great. And that's really where EndoAxis comes in. So at the beginning, Alicia warmly introduced me and mentioned that I am the CMO at EndoAxis. And we are a tech-driven solution for hormone evaluation. We are looking at those urinary metabolites. We are taking in all of the data from those Dutch tests, and we're scrubbing all of those metabolites and putting them through various equations that relate them not just to one another, but also to their downstream byproduct. Nope. So we're taking all of those analytes, we're scrubbing them off the report, and we're putting them through our system that analyzes and ranks them into 236 different patterns. And that's actually an asterisk because it's 236 times 4, depending on their cycle status and their age. We also have 96 male patterns. We have 22 birth control patterns that I didn't add to this list, but are kind of their own subset. And we have 14 adrenal patterns. So you don't have to remember all of that complex information that we went over to know what's impacting the hormonal status of your patient. You can run a Dutch test, and then you can analyze them through our system and really get that bird's eye view on the first 4 pages of a report that are highlighting and calling out what are major drivers of potential hormone imbalance. The reports themselves can be up to 20 pages in length because they really start to unfold all the information in greater and greater detail if you want that detail. But even the first few pages will give you that kind of bird's eye view summary of what you need to know for your patient's ultimate hormonal journey. So I throw that out there, but want to give you those perspectives for testing. So again, if we're looking at the fertility basics, if we're doing kind of that day 3, we want to look at LH and FSH. Those are the signals, the knocks on the door saying, hey, ovaries, are you ready? FSH is developing the eggs. LH is saying, okay, time to surge and rupture that follicle, time to get out there and make it to, conception or not. Estradiol, this is optional day 2, but it's nice to know they should be on the lower end, when they're actually on their menstrual period. But if they're too low or they're too high, there could be issues with estrogen on either end of that spectrum, right? Testosterone, good to check at any time. There's not as much cycle variance, but again, there is diurnal variance. So you do want to collect that before 11 a.m. ideally. And of course, sex hormone binding globulin. So capturing those kind of key hormones on that day 3. And of course, looking at that metabolic picture as well. There's a lot you can gather environmentally and nutritionally, even just from a thyroid panel, a comprehensive metabolic panel that's looking at your liver, kidney, and electrolyte function. Your complete blood count is looking at your white and red blood cells. Again, that blood sugar or blood glucose assessment and vitamin D level. Even beyond just frank, fatty liver risk factors or issues with electrolyte imbalance, or, with a CBC, you're going to see indicators of whether or not immune stress is present, or whether there's an issue for iron deficiency or B12 folate deficiency, looking at those red blood cells. You can also see, and I encourage providers, if you're running a metabolic panel, and that's your liver and kidney function, always tack on a GGT. GGT is a marker of glutathione recycling. So another great one when it comes to oxidative stress and wanting to reduce that stress. Like, what is their burden and do we need to support them? Again, progesterone, if you were looking at blood, a progesterone level above 5 nanograms per milliliter indicates that they likely did develop a corpus luteum, which, working backwards, means they did likely rupture a follicle and release an egg. But 5's not great for conception. We really want progesterone to be above 15, ideally. 10 to 15's suboptimal, but okay. Estradiol, this is when it should be surging as well. And you can look at a ratio. Now, keep in mind, estradiol is picograms per milliliter. So when you're comparing estradiol to progesterone, you have to convert estradiol to nanograms. That's 1,000 times smaller. Estradiol is 1,000 times smaller than progesterone. So 180 picograms of estradiol is 0.18 nanograms. That's how potent estrogen is. We don't make as much of it as we do progesterone, right? And that's how powerful progesterone is in the luteal phase. But it's good to see that ratio. And again, you do need that conversion. If you're comparing them, you want to compare apples to apples. And they're not on a blood test, so you have to do that conversion. And of course, doing a vaginal health screen. And I want to throw in, especially, so again, we want to make sure that they're not working against anything that would impair or damage their fallopian tubes or their endometrial health. So looking for STIs, yeast, Gardnerella, this would be on a general wellness screen. Alicia's going to go into a little more depth on a vaginal health microbiome assessment as well, but I want to throw out that that is also very important, especially for patients who are either working on IVF or who are struggling with infertility, and you've unfolded all of these layers and you're still just looking for that, like, what's the next test? Where else do we need to look? This may be the next step, right? Now, in males, we do like to look at estrogen and testosterone and get that ratio. Men should not be over aromatizing. Testosterone should be the primary hormone for men. So we do like to see around 2 to 5% conversion of testosterone into estradiol. Again, you do have to convert estradiol into from picograms into nanograms. And then sex hormone binding globulin, we want to make sure. I always think of sex hormone binding globulin as like a little taxi cab. It's shunting and shuttling hormones throughout the body. It preferentially binds testosterone, DHT, and then estrogen, estradiol, and estrone. It's not going to bind progesterone. Okay. Now, DHEA has its own bound. It's a bound sulfate group, but you can look at DHEAS in serum as well to get more of an adrenal health status. And of course, the thyroid metabolic panel, CBC, glucose, and vitamin D. In men, testosterone in urine can be tricky to assess. So I always recommend testing it in blood as well. And with men, definitely get that serum testosterone because urine can under capture testosterone due to a glucuronidation, an issue with UGT2B17. You can have a single deletion or even two deletions that alter how well you clear testosterone into urine. But that's the one caveat that I'll throw out there. Now, that was all your basic assessment. Once you get to that 6-month mark of they're failing to conceive and we don't know why, right? We've done all their initial workup. Everything's looking good. We've checked in on all of those metabolic parameters. We're starting to assess with nutritional optimization, with stress management, with herbs and nutrients that are supporting hormone balance. Still struggling. This is when we start doing more of those advanced tests. This is what we would consider an infertility workup, including anti-Müllerian hormone, prolactin, which, 3 to 10 is really our ideal functional range. Although above 23 is when we have to start thinking imaging for a prolactinoma, which is the most common benign brain tumor. That said, it's not that common. It's just the most common of the tumors. But 3 to 10 is kind of ideal. 10 to 20, that doesn't mean that they have a tumor or a prolactinoma, but it can mean that they're under a lot of stress. And when prolactin starts to elevate, when you're under a lot of stress, cortisol goes up, prolactin starts to go up, and that can suppress how much progesterone is made by the corpus luteum. So we want to monitor prolactin. 17-hydroxyprogesterone is run if there's concern for what's called late onset or non-classic congenital adrenal hyperplasia. This can mimic PCOS, and researchers actually suspect that it's more common than we once thought, simply because often these women are diagnosed as PCOS patients because that marker is not run. And yet it's this 21 hydroxylase deficiency that's causing androgens to elevate, specifically from adrenal sources. So often you'll see very high testosterone, very high DHEA as well, and totally normal progesterone because it's not impacting the ovary. It's actually adrenal driven. One that you can definitely run as well. And then looking more at those inflammatory markers if we need. If the CBC is suggesting from our basic panel that there is an iron deficiency, we want to do more advanced testing to look at ferritin, iron, transferrin saturation, right? Iron is critical as a key coenzyme or a cofactor for just cell replication, right? So when it comes to fertility support, we have to make sure the ferritin is optimal, that their iron levels are good. Now, iron can oxidize, so we don't want to push them too high, but we do want to check in on their status. Again, autoimmune screening if needed, or if their history would suggest that there is concern there. Micronutrients can also be tested. Environmental and GI health panels may also be assessed. But again, you can start to determine where you want to look, like that Dutch chest I showed you earlier. My next step there would be definitely to run a GI health panel, right? Because there's so many indicators, high cortisols, high 16-OH that are saying, okay, we probably need to look at the gut or just even treat preemptively and assess, further down the line if things aren't getting better. We do have imaging as well, which when you're starting to look at infertility, you want to start looking at a pelvic ultrasound. Do they have the right patency? Is their endometrial response looking optimal? Hysterosalpingogram, that's the advanced test if you're looking for scarring of the fallopian tubes. And again, if you have a female patient with history of chlamydia, even though it's been treated and resolved, you may want to test just to make sure that there's not residual scarring that's impairing her ability to get the egg to the endometrial tissue, to that uterus, right? And then diagnostic laparoscopy would be if there's an endometriosis risk or concern. More advanced testing, you're looking at LH, you're looking at that semen analysis. And I want to point out the WHO guidelines as of 2021 say that for normal sperm morphology, you need at least 4% normal sperm. That's it. That's their threshold. They're like, hey, 4% is normal. They're doing good. I would argue you probably want more to like 14% normal sperm on a semen analysis, but it's, but I thought that was very, very fascinating, very eye-opening. And again, kind of shows us the low threshold that we need to actually conceive, but how we may want to ensure that we really are optimizing sperm, because even if it's, normal, it could still be suboptimal sperm quality, right? And that sperm quality is going to impact the trophoblastic layer of the blastocyst, the placental development, the risk for preeclampsia, the risk for preterm pregnancy, and even the health outcomes of that baby. So really want to make sure that we're optimizing sperm. Prolactin for men as well can suppress testosterone, of course, inflammatory markers there. So I know I'm about at time. I did want to throw in just this. This was actually from Medscape. I always like watching Medscape for things when they throw out like, hey, could nutrition be an important fact that or feature of, why 1 in 6 patient or couples is facing infertility? Could nutrition be the missing link? When conventional doctors are saying this broadly, it's like, oh, hooray, yes, of course they can. As functionally trained doctors, we already know this, but it's great to see that conventional docs are finally catching up and that it really is very important, right? And I specifically at the bottom here want to call out that the key nutrients they found to be most supportive for sperm health specifically was vitamin C, vitamin E, selenium, zinc, CoQ10, and omega-3 fatty acids. And that kind of brings us into our formulations, because not only are we a text solution, we're not only analyzing the Dutch, but we have 26 formulations that are targeted to the kind of those unique features or imbalances or patterns that we're finding that could be impairing patients' ability to conceive or just to manage or balance their hormone health. And Formula 12 specifically is our Nerve2 kind of potent antioxidant supportive blend. It really does emphasize most of those nutrients. The one we don't have is the omega-3 fatty acids, and that's because they really don't play well with other micronutrients for shelf stability. You want to do like a good fish oil in its own well-defined, good professional product development solo, right, with food. But all the other micronutrients are there, right? Because this is our antioxidant blend. We give this just as an optional product with our system anytime 4-hydroxy or 16-hydroxy is elevated. But this can really be a great product for any couple trying to conceive, both male and female partners, because it's helping improve sperm quality. It's helping reduce oxidative stress, improving egg quality. It's a great antioxidant, and it's very supportive, right? It's not going to like overdevelop or, trigger any other physiologic response that we wouldn't necessarily want. It's really just all supportive response. I do like to throw this if you're wondering, what does Nerve2 support mean? Well, Nerve2, we're using TrueBrock in our Formula 12. It is a heat stabilized glucoraphanin, well documented, patented for its both bioavailability and efficacy at improving Nerve2 response. It will bind with myrosinase, which your gut does make, but we also add mustard seed, which is that added myrosinase. You want them to conjugate together in your body. You don't want to give sulforaphane solo because as an antioxidant, it's very delicate. It's going to just denature in your stomach acid, right? So when you're giving glucoraphanin with myrosinase, you're able to get that response into sulforaphane directly at the cellular level. And what it's doing is it's actually uncoupling Nerve2 from the keep protein, which allows Nerve2 to go into the nucleus of the cells, upregulating glutathione synthesis, catalase, SOD, NQO1, which is our NADPH quinone oxoreductase enzyme. That's then triggering conversion of our vitamin E into active tocotrienols, our CoQ10 into active ubiquinol, and really supporting that oxidative response and free radical, protecting from free radical damage to that cell. Formula 4 is kind of for any woman who's cycling. This is a great blend to really support HPO axis. 21 for men, great for inflammation, great for androgen support. And then our adrenals, because adrenals and stress are so important. 16 is for our pro-inflamed, hyper-stressed individuals. Blood sugar imbalances are another big one that this will target and support. Whereas on the opposite side, Formula 19 for our adrenal blend really targets mitochondrial health. And anyone working on fertility can benefit from really supporting mitochondrial health as well. So this is a great one just as an add-on, even if you don't test. Formula 4 for women, Formula 21 for men, Formula 12 as antioxidant support, and 19 for that adrenal, thyroid, mitochondrial axis, kind of all those nutrients. Great blends that you can use with any patients right out the gate. But I always like to say with Endo Access, just as our final wrap up, it's all free to sign up for an account. Throw that out there as well. Free to sign up. You're getting our hormonal support. You're getting a help center. You're getting our customized formulations, all in glass, Because remember, plastics, even from supplement bottles, there is that concern that you're going to get some of those nanoplastics of off-gassing onto those cellulose product, onto those capsules. So we store all in glass to really reduce that plastic exposure, both to the patient, but also to the environment. Again, we're hopefully saving you time, giving you great access to well-developed, well-researched products, and really giving you that thorough assessment. So I'm going to pass the baton. I do have my references here that you will get in the slides, QR code to our EndoAccess site, but also endoaccess.com. Passing the baton now over to Alicia to really dive into the vaginal microbiome and vitamin D importance. Let's see if I can exit out here.
Great. Thanks so much. And mine will be quicker. So, but thank you so much, Dr. Bartman. Really wonderful information. And what I want to do is kind of bring some of the concepts that she discussed and relate that back to the vaginal microbiome, and the importance of that as it relates to pregnancy and miscarriage. If you have been listening to some of our conversations, we've been talking a lot about the vaginal microbiome and just the differences of the vaginal microbiome compared to the gut. One of that being low bacterial diversity. We don't want to have a lot of different types of species in our vaginas. We want it to be predominantly lactobacilli. And that's because lactobacilli help to keep the environment in a really great state of acidity. They produce different byproducts that are antimicrobial to keep pathogens at bay. And we have predominant species that are characterized in a healthy vaginal environment, like Lactobacillus crispatus, Gasseri, Jensenii, and Lactobacillus einers. And so these are the top 4 that are usually found in a healthy vaginal microbiome. And as Dr. Bartman was just talking about, there's lots of different factors that can influence fertility and from many different angles, but a lot of those can also influence our vaginal microbiome environment, such as our diet, as she was talking about the different plastics and the linings of takeout and low antioxidant status, hormonal changes like estrogen and progesterone, sexual activity, sexual practices, hygiene practices, medications, and stress, and then genetics. So a lot of what she was talking about that influence overall fertility from our adrenal standpoint, our detoxification standpoint, those all are going to also influence our vaginal environment. Now, it fluctuates during a woman's lifespan. So our reproductive years are characterized by higher levels of estrogen as well as in pregnancy, and that's going to affect the amount of glycogen that's available for our lactobacilli to eat. Estrogen drives glycogen production. So if we have optimized levels of estrogen and proper estrogen recycling, then that's going to allow for a better environment for our lactobacilli to feed off of, and that's really what we want. Whereas pre-puberty and then postmenopausally, those estrogen levels are really low. And so we don't have that glycogen, we don't have that fuel source for the lactobacilli. So there's definitely a shift over a woman's lifespan. Now, a healthy vaginal environment, as I mentioned, this is just what it looks like in picture form, where we have lactobacilli that are producing those beneficial byproducts that are inhibiting pathogens, producing that lactic acid. And so that's going to create an environment that's less likely to have pathogens come in and invade. However, if we don't have lactobacilli, then we don't get those protective byproducts. We don't get that lactic acid production. And so that can set us up for different things that can influence a pregnancy or can influence fertility. Different vaginal infections or pathogens can come in, and that is going to have an effect on a woman's fertility success, and then also keeping the pregnancy, as we'll talk about. But let's talk about how it links into the gut as well. So we know that there's a maternal fetal microbiome connection. We know that the infant microbiome is developed and matured by the maternal microbiome. We know that there's also a component of the maternal microbiome that influences the breast milk. And we also know that the health of the mom's gut, and if she has gut dysbiosis, is going to associate with some different immunological outcomes as well that we need to be considering. And I just realized I'm not on camera, so I'll take myself off of camera here. And so these are some things that we need to think about, especially when you're working with these populations. And part of how the immune system is influenced is when we have dysbiosis within the mom's gut, that can lead to an increase in inflammation and inflammatory cytokines that can affect the immune response in the offspring. Now, I think this is a really interesting, and if any of you have worked with, and as Dr. Bartman was talking about, just that risk of miscarriage or recurrent miscarriages. I know some people were talking in the chat about some of the experiences that they've had with this. And so you know that this is probably one of the most emotionally just challenging events that can happen to a woman in the fertility journey. It's such an emotional and sometimes very traumatic. I mean, there can be a lot of emotional pain that can go into this. And so, like she was saying, we have to think about all the factors that can lead to this. And of course, there are going to be situations where we just don't know. But we have to at least look at all of the different factors because in this case, this is showing how the vaginal microbiome can influence the risk of miscarriage. If someone has a predominance of lactobacilli, then that is going to be much more protective and it can actually lower that risk of miscarriage versus having a more dysbiotic vaginal environment, having some pathogens that potentially are able to establish in there. That's going to activate the immune system and it can actually change and influence uterine contractions and fetal membrane remodeling, and it can increase the risk of miscarriage. This is a paper that reviewed 16 different trials on the effect of the vaginal microbiome in miscarriage. And what they found, and again, you'll be getting these slides, so I'm not going to read all of this, but I've underlined for you the key points that in every case, whenever there was vaginal dysbiosis or there were the presence of different pathogens, that increased the risk of pregnancy loss, and in some cases, late pregnancy loss into the second trimester. Whereas when there was a predominance of lactobacilli in the vagina, then there was actually more of a protective element to that. And so there was a less of a likelihood of having a miscarriage. So certainly there is a strong correlation between the microbiome composition in the vaginal environment and the effect on pregnancy loss. Also, same thing with preterm delivery. So community state type 3 or 4 are considered the less healthy community state types in the vaginal microbiome. And so when women have these community state types, they have a higher risk of emergency C-section. This was looking at just the diversity and the abundance of lactobacilli, especially Lactobacillus crispus, in helping to reduce the risk of preterm delivery. And in this one, looking at Gardnerella, which is what causes BV in the setting of low lactobacilli, can be a contributor of preterm labor. So certainly an association there. I want to touch on vitamin D because Dr. Bartman did discuss that, and I want to go into that just a teeny couple slides more on that because it's really an important element that we consider with our clients as we're doing the assessments that she was talking about. So we know that vitamin D is playing that role in both male and female fertility. We have vitamin D receptors in all of the different reproductive organs, and it also helps to increase the production of those different steroid hormones that she was discussing, like progesterone and estradiol. But AMH levels, which is something that is a big buzz in the fertility world, is what is your AMH level and what can we do about it? Interestingly enough, AMH levels decrease by 18% in the winter compared to the summer. So depending on when you're testing AMH levels, but when you supplement with vitamin D, it actually prevents that change. So there's a seasonality to AMH, and vitamin D supplementation can actually improve those AMH levels to some degree. Of course, there's lots of variables that can be related to AMH depending on your age and if you have premature ovarian failure, but it's something to factor in of when somebody's having their AMH levels tested and what their vitamin D level is. When it comes to males, so again, talking about it takes two to tango. We can't forget about our men in the conversation, but making sure that their vitamin D levels are also sufficient because that can correlate with better spermogram results than men who have vitamin D deficiency. So optimizing our male partners to ensure that their vitamin D levels are sufficient because that will influence the sperm. Now, if you have patients going through IVF, vitamin D strongly correlates with success rates. For every nanomole increase in vitamin D, the content of the follicular fluid increases the probability of clinical pregnancy by almost 2.5%, which you think about that, that can become significant. That can be the difference between a pregnancy and a non-pregnancy. So especially for these women who and couples who are going through IVF or reproductive treatments, this is an absolute critical element that must be looked at. And if we look at, this was looking at the influence of vitamin D on reproductive outcomes. So it's 12 studies that were included, 9 randomized, and then 3 cohort. And they were looking at women who were infertile, who were given vitamin D supplementation, and how that increased the clinical pregnancy compared to the control group. And there was a significant increase and a significant difference between those two. So just want to drive home that vitamin D, we know it's important for our immune health, for our immune system, but for this population of women and couples, we cannot forget this piece. So what do we do about it? Well, probiotics are one element that is an important factor, and I'll tie this together when our fertility protocols and fertility recommendations, combining both what Dr. Bartman discussed and then also some of the solutions that we have. But I want to cover a couple of blends that are really interesting and have been studied in our vaginal health. So this was a study that was done in bacterial vaginosis. They compared the probiotic to metronidazole. And what they found was that, well, everyone received the metronidazole, and then one group received a placebo and one group received the probiotics. And those that received the probiotics, 100% of women no longer had or met the diagnostic criteria for BV. We know BV is one element that can prevent a woman from getting pregnant. It can be detrimental for IVF success rates. It can be a driver of miscarriage in some cases. So really interesting to see that the probiotic group saw those types of results from taking it. The group that did not receive the probiotics, there was only a 64% recovery rate. So even though everybody received the antibiotics, only the group that received the probiotics actually had 100% of women who were recovered. There was a significant reduction in the Ansel score and significant reduction in symptoms. This was another study that was done looking at basically a model of vaginal dysbiosis, and they looked at the probiotics compared to a placebo, compared to, they were all in pregnant women. And what they found was that the probiotics resulted in a 200% increase in their lactobacilli colonization. And there was also a significant improvement in different symptoms like vaginal itching, as well as a significant reduction in the vaginal pH. So 58% fewer women had a pH above that 4.5, which is much too alkaline for a healthy vaginal environment. Now, LGG is something that is also interesting from an immune standpoint for helping with the immune system in pregnancy and also affecting the offspring. This was a study that was done, it spanned about 7 years, actually, so it was in 3 different parts. Women who were pregnant received a placebo or they received the LGG for about a month or so before their expected delivery. And then when the babies were born, half received the LGG probiotic and the other half were the moms just continued the LGG. So only half of the babies received it directly for about 6 months, and then they stopped it. Then they followed up at 2 years, 4 years, and 7 years old. So after they weren't taking probiotics, they stopped at that 6 months postpartum. But then they checked in to see, well, how did that affect, having the mom take it in pregnancy and the babies taking it? Did that make any changes 7 years later with different immune system outcomes? And what they found was that there was a 50% reduction in red and scaly skin at 2 years old, a 43% reduction at 4 years old, and by 7 years old, there was a 35% reduction in red and scaly skin in those that received the probiotics. Not the case for those who received the placebo. And it didn't matter the route of delivery, whether the mom took it and the babies received it from the moms or whether the babies received it directly. It didn't matter. It just was as long as they were getting the probiotics, they saw these results. And that was not the case for those that received the placebo. So illustrating the point that what a mom does in pregnancy can influence sometimes what happens up to 7 years later. And then finally, the Istilos strain, which is actually a bifidobacterium strain. There was a study that was done where the moms were taking the probiotics again for about that month before delivery. and then for 28 days after, and then there was a 2-week washout. And what they found was that in the infants where the moms and were receiving the probiotic, and then in the infant group that received the probiotic, that it did come out in the stool, so that it was present in the stool of the babies. What they found was that in the infants where the mom was taking it, so the babies were not getting it, there are about 30% of the infants, it was found in their stool, showing that there was some transfer from the mom to the baby. But there was also a significant increase in butyrate in those babies. And we know that butyrate is really critical for improving immune health and educating the immune system and development, as well as helping with our epithelial barrier system in the intestines. And so really that fuel source for those colonocytes. The other interesting thing was that the strain actually increased after the washout period. So typically when you take a probiotic, it's in your stool while you're taking it, but then usually about up to 2 weeks, later, a week to 2 weeks after you've stopped taking it, it's no longer really detected, or there's a significant drop in the amount of that strain in the stool. That's what typically happens. In this case, this strain increased after the washout, which suggests that there was some engraftment. Engraftment is when a strain takes up a residence in the gut versus just being transient. So that was an interesting outcome of the study as well. So how do we pull all of this together and put it into practical applications? This is our pregnancy support. It includes the LGG at the dose that I was mentioning in the study on the red and scaly skin, as well as the Astarte blend, which is for vaginal balance with our microbiome, and then the Isolose, which is that strain that's more specific for helping to educate the immune system of the infant. And so we really recommend that this product is great for women who are at least 33 weeks pregnant, who have just recently given birth and are breastfeeding or pumping, because it works really well in the presence of breast milk and those different HMOs. If they're wanting to just support their vaginal health during pregnancy, or if they have a family history of skin sensitivities and they want to support their baby's skin health. So for putting it together, if you walk away with nothing else, you can walk away with these last 2 slides. And I don't know, Dr. Bartman, if there's time in Q&A to discuss this a little bit more if people have questions, but you can see these are the various ones that she recommended from EndoAxis that provides everything from antioxidant support to healthy sperm motility to female hormone balance, adrenal support. So all of the different complex elements that you'd want to think about when working with couples who are striving to get pregnant. And then when you're looking at the microbiome and that gut health element, considering depending on someone's vitamin D levels, supporting with vitamin D, helping to improve our gut health with something like Megaspore, as she was talking about, gut health is critical when it comes to hormone balance and detoxification. Of course, our pregnancy support, as I just talked about, with the various clinically researched strains. And then one element that she discussed was the stress and how important stress reduction is in adrenals. And our ZenBiome Dual is a gut-brain psychobiotic blend. And so looking at how do you support adrenals, maybe from some of the herbal realm, but then how do you also support stress and brain inflammation from a gut brain standpoint too. And so those are just some other additional suggestions that you can consider for some of these patients. Last thing I want to mention is our Microbiome Keynote Symposium, which is going to be in September. We are going to have amazing speaker lineup. EndoAxis, who you just heard from, will be there as well. So you'll get to meet Dr. Bartman at this MBKS symposium that we are hosting in Nashville. So definitely check that out. Here's the QR code. If you're interested in coming and joining us, we would love to have you and interact with the amazing list of exhibitors that we have as well. Very diverse group. And so there's lots of really wonderful opportunities to engage with these various companies. And with that, I will end with any feedback you have for us. We'll go through a real quick Q&A, and then we'll wrap it up with just a final comment. So And yes, if you need to hop off, you're welcome to hop off there. We will continue to record. So, um, okay, let's go through a few questions. Dr. Bartman, can you speak to the potential of oxidative stress and inflammation from breast implants?
Great question. And I think, yeah, it's with breast implants, it's so tricky. Really, where they're finding breast implant illness is from basically a biofilm that forms around the implant itself. It's creating a low-grade state of immune dysregulation and inflammation. And that can lead, I mean, anytime you're augmenting your immune system, you're going to make for what I would call like more of a hostile kind of uterine environment because there are so many immune cells that have to work in concert to really optimize both that implantation, but also success for development once implanted within that uterine tissue. So really making sure that, we have that appropriate balance of the interleukins and prostaglandins, that our histamines are in a good place, but not too high. And with breast implants, if there is that kind of biofilm, that microbiome or that bacterial kind of dysfunction at play, that can definitely throw off the immune system and make it harder to conceive. Is it a direct impact? The research is still limited. If you go into PubMed and search that, they'll say it's like mixed, right? Like that's not conclusive. But if you think about what's happening, and researchers have definitely shown that kind of biofilm disruption and response. Yeah, if you're throwing off your immune system, you're throwing off your fertility success for sure. Hopefully that answers that.
Yeah.
Yeah.
Do you have any resources for test kit providers in Australia, if not working with a physician?
For the
Um,
Dutch test?
yeah, I'm not sure if it's for the Dutch test or, um, yeah, I'm not sure. And I'm not sure who asked this question, but I would say you might want to just check your resources in Australia, or reach out. If you are referring to Precision Analytical and the Dutch testing, do you know offhand if that's available in Australia?
Yeah, it is. We definitely have worked with providers there. It's through a distribution. I want to say it's Regeneris, maybe. It's
Yeah,
definitely it's a private just lab distribution
yeah.
company.
You may want to
Uh,
just reach out to them and get
yeah.
further clarity on that. So,
Mhm.
should a toxin screen be done prior to pregnancy?
Absolutely. I think so. Because here's the thing, and this is really so the placenta concentrates toxins. It is a detox organ. And it will amplify any toxins in circulation. It will harbor and contain. And a part of that, it makes sense in terms of evolution, right? We want to bathe our babies in potential threats. We want to prepare them epigenetically to start programming for the environment they're going to be exposed to. So it makes sense that the placenta is going to concentrate all of our toxins, but at the same time, our toxic burden is really high right now. And yeah, I would definitely want to screen and support, and do not do any chelation or anything that would pull toxins out of storage if you're looking to conceive within a year, because you don't want that coming out. Like, see what's in circulation. Don't do a challenged or provoked test, I guess is what I'm saying, because you want to see like what's in circulation that will concentrate. What's stored in bone, that's not going to come out unless you provoke it. Keep it there. Right? Because we don't want it to circulate and then concentrate in the placenta. So, yes, I think it's important to screen. I also think it's important to treat, but treat at least a year or more prior to any desired conception. Yeah.
Can we provide direct ordering for patients? I think this is regarding your
Oh,
EndoAccess.
our products? So our products are available in full script right now. So, and that's really the only way to link to them. So if you have, they are open within the catalog, but the patient would have to have an account, right? Which means I think you have to link with a provider or have like you just, as long as you have a full script account, you will see our products. I guess is the short of that.
Yep. Someone's asking AMH level, or AMH is anti-mullerian hormone. It's essentially just a measure of female ovarian reserve. And so typically as a woman ages, that level goes down because you're losing more of your ovarian reserve. But there are cases where you have younger women who have low AMHs, and that's a premature ovarian failure. So it is possible sometimes to have that lower in some young women. So I don't know if you have anything else you want to add to that, Dr. Bartman.
And conversely, high levels can be a predictor of PCOS.
Yes. Yep. Is it fine to start pregnancy support earlier in pregnancy? You can, yes. The 33 weeks is just what the studies have been done, and so that's what we recommend. But it's LGG has been studied in pregnancy. Astarte was actually derived from pregnant women. The Bifido is fine. So it's okay if you want to use it a little bit earlier. Can you speak to the risk of oral progesterone on the microbiome? If thoughts on that.
So interestingly with progesterone, I mean, so progesterone and estrogen, they're like yin and yang. They have a lot of activity in the body, not just in the womb, right? But we definitely know that estrogen is our driver for follicular health. Progesterone is our supporter of endometrial development and pregnancy success. But outside of that, right, progesterone plays a role with GABA. It's a GABAergic promoter in the brain, that a specific metabolite called allopregnanolone. Whereas estrogen supports dopamine and serotonin activity, right? So we have like this yin yang balance of neurotransmitters. Estrogen actually supports motility of the gut. It supports serotonin in the gut as well, which again is that motility response, whereas progesterone can slow things down. It slows everything down. It's kind of helping us prepare to like absorb our nutrients. It also creates more laxity. So progesterone helps us get stretchy so that we can expand, so that we can grow a baby and then deliver that baby, which, is no easy feat. So progesterone is really that preparation hormone. And when you take oral progesterone, number one, it's hitting the gut at about 80% clearance, whereas only 20% of what you take will actually absorb systemically. So about 80% of that progesterone is just going right into the gut, getting conjugated out, but impacting the tissue. Number two, it's creating ligamentous laxity. This can do a number of things for digestion. It can make the lower esophageal sphincter a little weaker, and that can lead to more bloating, more nausea, and even more like acid reflux. In fact, I have some patients who just cannot take oral progesterone at all because acid reflux gets so severe. It's also going to kind of slow the motility a little bit, right? And so when you're looking at direct impact to microbiome, I don't think there is that I know of. I don't know a direct impact, but definitely on the mucosa, on the motility, and on the response that would then lead to potential dysbiotic like activity. Progesterone could play a role there a little bit, but more so, it's more what it's doing to motility and what's doing to the ligaments, like the lower esophageal sphincter. Do you know of any others, Alicia, about like the actual biome response?
Yeah, so I mean, I think it depends on, like you were talking about, the form as well. I mean, I think there's also the balance between, you need the progesterone for
Yeah.
this. And how do you mitigate some of those effects through whether it be diet, stress management? I mean, there's many different things that you can do to mitigate some of those effects on the microbiome as well. And it's like the vaginal microbiome too. Progesterone has an effect to some degree on the vaginal microbiome in a positive way, though, like kind of like estrogen. Do amalgams affect pregnancy outcomes, i.e., low gestational rate, premature birth?
I don't know any direct link. Of course, you're looking at aluminum or mercury in a lot, and then plastics in the newer ones. And the old one, like the old ones are like more aluminum and mercury based, and now we have like plastics. But in terms of what's getting in circulation, and I don't know of any studies that actually have directly looked at that. I know that there is going to be a little more, risk for toxic exposure because of them being present, but it's a very small amount,
Yeah.
and depending on how many you have and how old they are, and like there's a lot of variability to it. Um, I would say, if there is concern, just supporting immune response and inflammation is always the key, no
Yeah.
matter what.
Yeah. Perfect. Well, that is all of our questions. And so thank you all for hanging in with us. This was going to be a little bit longer webinar, but it is recorded. So if you needed to hop off early, that's totally fine. You can come back and listen. And thank you all again for joining us today or for listening to the recording. The slides and the recording again will be sent out by the end of the week and also uploaded onto the webinar section in the MBL website. So if you have an account, when you log into the back end, you'll see on the left-hand side under education, the webinars will be there with the presentation slides included as well. So Thank you all, and thank you so much, Dr. Barkman and Endo Access for joining us and delivering such a wonderful presentation. And we look forward to seeing you all at our next webinar or next educational event, which will be coming up in July. Another hormone perimenopause mini keynotes conversation with Dr. Lindsay Moreau. So be on the lookout for those educational emails on when you can catch us next. So without further ado, I thank you all and have a great rest of your day.
Thank you.
Take care.